Hi, thanks for joining us today. We'll talk about Speckle tracking echocardiography and particularly its relevance in the critically ill. I hope this is useful. It's a bit of an obscure topic, some might think, but I think it's becoming more widespread, and anyway, I hope this is useful. Okay, so we'll go over a few physical principles of Speckle tracking, and then particularly going to talk about how to actually perform some of these measurements, and most importantly, the limitations. And finally, we'll get a chance to have a look about how it might, maybe not be of use in the critically ill. So the purpose of Speckle tracking is the idea is you can pick up subtle dysfunction, right? Is the idea that some of the conventional measures that we have, they can miss subtle dysfunction. That's the original premise of it. So particularly the example here is about ejection fraction. Ejection fraction is not a perfect way of picking up systolic dysfunction, and maybe Speckle tracking can answer some of that. So that it would be to try and pick up, for example, if someone's asymptomatic with some LV diastolic dysfunction, for example, we know that there's that continuum between diastolic dysfunction to severe systolic dysfunction. In somewhere there, you're going to start to get symptoms. And so the idea is that maybe you can start picking up some subtle dysfunction and you can start trying to treat it before we start to see the symptoms progress. That's where the theory of all of it came from. In terms of the critically ill, my argument would be for something like, let's say, the right ventricle. If you could use Speckle tracking to start to pick up some subtle RV dysfunction, maybe we could institute measures such as reducing PEEP, watching for fluid overload, instituting earlier catecholamines rather than fluid. You know, maybe these are some of the measures that may be able to help in the critically ill. Again, that's very research-based, but in the cardiology literature, certainly this concept has been shown to be of use in things like oncology, the chemotherapy-induced cardiotoxicity. We know that global longitudinal strain can pick up problems before they are picked up by ejection fraction. And we know that this is the kind of technology that has helped prevent serious heart dysfunction because chemotherapy is changed or reduced or stopped when you start to see earlier cardiac dysfunction. So it's got some premise of being useful in the cardiology literature. So what is it? Well, it's sort of what it says on the tin, to be honest. It's the idea that if you start with an echo image, it's made up of little speckles. And when you've got this technology, you sort of paint the myocardium, if you like. And once you've done that, this technology, it latches onto some of these speckles, which are actually, they're called kernels, is what they're really known as, these little tiny little speckles that you can see here. And these kernels are like a fingerprint, if you like, because they stay stable throughout the cardiac cycle. They're not real structures. They're made up of these destructive and constructive sort of scattered ultrasound waves. So because some of the myocardial fibrils are really small, they're actually smaller than the wavelength of an ultrasound beam. And so as that hits the myocardial fiber, it sort of scatters. Some of those scattered waveforms, they can join together and make a bright area, and some of them sort of knock out each other and make a dark area. But it makes a relatively sort of like specific area on that myocardium. And that's what the software can sort of latch onto. So they latch onto those speckles and then they watch as they move through that cardiac cycle, as you can see over here. So two speckles are locked. You watch them go through from diastole to systole and back again, and you make a simple equation, and that's how you get the parameter or degree of deformation, which is known as strain. So here's a beautiful slide that's sort of put together. It's by Stephen. And you can see as the heart moves, these speckles, this is what the software sort of latches onto and what the change over a cycle. So yeah, that's the premise of Speckle tracking. So it's an estimate of deformation, right? What we mean by that is how something deforms over a time period. So if we start with something that's say 10 centimeters long, or call that 100%, and then it squishes down to being 7.5 centimeters, or 75% of what it was, that's a 25% deformation in a shorter version, which means it's a negative 25% deformation, and we call that strain. Okay, so strain is the measure of deformation of a structure by Speckle tracking. Right? So there are different values for different ways that we can look at. We'll start with the LV. Right? So the LV, you've got longitudinal deformation. So that's how it's going to change from apex to base. There's radial deformation when we look at it in the short axis of how much the myocardium thickens as it contracts during systole. There's circumferential differentiation, where again, if you look at it in the cross-section of the heart, there's how the speckles come together as that heart twists round, because as you remember, the heart sort of twists and elongates in 3 dimensions as we look at it. And that's what's known as circumferential deformation. Everyone's probably going to recognize these bullseye plots that we're starting to see as well. And that's based on longitudinal strain. So longitudinal strain is the most commonly researched. It's the most commonly one that's imaged. It's the one that is in the mainstay of cardiology literature as for things just like I explained. So it's used for chemotherapy-induced cardiotoxicity. It's used for looking at subtle hypertensive disease. It's used to look at subtle systolic dysfunction from things like amyloid or hypertrophic cardiomyopathy or simple heart failure, right? These are the areas that has been looked at in the cardiology literature and shown to be of use. We can look at the heart from sort of 3 sections, as you remember from standard imaging, right? You've got your 4-chamber view. You can then rotate that round 60 degrees and you get or 90 degrees, 69 degrees, and you get your 2-chamber view. Go on another 60 degrees and you get your apical long axis view or your apical 3-chamber, whatever you want to call it. And remember that each of those look at slightly different ways. And when we start adding them together, we get our bullseye plot. So I'll just show you here. I've got the inferior wall and the anterior wall. So that's the 2-chamber wall. Okay. Here I've got the infraseptal and anterolateral. So that's my apical 4-chamber. And over here I've got my anteroseptal and infralateral posterior wall, they call it here, which is the apical 3-chamber. When you're doing a longitudinal strain, each one of these strain curves corresponds to a different segment. So we've got a 17-segment model. And what the bullseye plots is basically a pictorial representation of these 3 graphs added together. And it says that red is normal contraction, which for the left ventricle is more than minus 17%. So if it's minus 17% or more, it's dark red. If it's starting to get closer to white, it's getting less and less and less and less deformation, so less and less and less strain, so less and less and less systolic function. So obviously 0 is no movement at all, severe systolic dysfunction. Minus 10 would be a little bit of deformation, so that would be moderate, severe systolic dysfunction. And then minus 15 would be mild systolic dysfunction, right? It can go all the way to blue, which is where we're getting dyskinetic movement. So that means that the myocardial fibers are stretching out instead of going towards each other during systole, and that's blue. But on a pictorial representation like this, it's all red. You can just look at it, and there's a way of eyeballing it to say, yeah, that's normal strain. If we add all of the segments together, take them as an average of the 17-segment model, you get global longitudinal strain. Minus 17 is normal. I use about minus 14 or so as being the mild to moderate, minus 10 or 11 to being going from moderate to severe. And that's what the evidence basically suggests. Okay, so global longitudinal strain, most commonly used. Red is normal, white is akinetic, blue is dyskinetic. So we can get pictures like this. Louise, do you want to have a crack at telling me what you think the pathology might be for this one?
So there's regional abnormalities there.
Nice.
Most obvious is the anterior wall looks dyskinetic.
Yeah, cool. So here we've got 3. So 3 is blue, that means dyskinetic. You can see the scale up here.
The basal segments predominantly, and some of the mid segments also show severe impairment.
Very nice, because we're white or just light red. Yep.
And it's only the tip of the apex that comes close to being normal, but even that is not normal because minus 12 is the biggest number that I can see. Well, the lowest number. So in summary, we'd say that the
apex has more systolic function than the base, but it's all a bit rubbish.
Yeah.
Cool. What do you think what pathology might give that?
Okay, so the cherry on top is consistent with amyloid,
Nice.
but may not be amyloid. Could be another infiltrating disease.
Yep. Could be
So
ischemia. I guess it could be dual vessel ischemia with the right coronary insert,
Yeah.
for example. So perfect. And I guess what I'm trying to use from that is to say that strain will give you an idea. It is not perfect. The cherry on top, we talk about being pathognomonic for amyloid, but again, other pathologies can show similar kind of appearances. You know, unfortunately, echo is not perfect, as I probably don't need to tell this. Okay, so which of these Ball's plots might represent a stress-induced cardiomyopathy? Is there anyone online that wants to have a go at saying that, or can we grab Louise again? Which one would be a stress-induced cardiomyopathy?
B or C.
B or C? Oh, hey Sid, what do you reckon?
Yep. So stress-induced one, that means, say if it is a Takotsubo cardiomyopathy, that means
Yep.
apex is dilated.
Yep.
And so apex is going to be either blue or white.
Nice.
And the base is also probably B. And B
Cool.
is probably going to be.
What do you reckon C might be? Because C's got a bad apex as well, right?
But probably, yeah.
Yeah,
B or
it
C.
could be. It could be.
Yeah.
What about this area down here? So we've got anterior and the anteroseptal.
Yeah.
We've got -5, -8, -5, -5.
I was going to say there is some kind of regional normal motion in
Yeah.
channel C, so it may not be the C. But
And this might be, I guess I was also thinking with this one, is if you've got the basal or the mid area, so
Anteroceptal, so that'd be inflamed.
yeah, it could be LAD territory and function. Again, I was just trying to illustrate the point that we know that stress-induced cardiomyopathy or Takotsubo is a diagnosis of exclusion, and you've always got to exclude LAD territory infarcts. And it's not perfect Speckle tracking. Actually, both of these patients were a Takotsubo patient, but good example to show that we've got to go looking for LAD. Sticky. Cool. Okay, the other thing I find fascinating about Speckle tracking, and this is where maybe the love-hate relationship that I have with Speckle tracking comes from, is that you can get a lot of information from it. And this is good and this is bad, okay? So let's talk about the information I'm talking about. So the information here, this is a standard strain curve that we can get for someone who's had one segment that's been traced. You start here at the beginning of systole, so the beginning of the QRS. We go through to the end of diastole, which is towards the end of the T wave. And then it goes back to where it started, the beginning of the QRS again. So that is one cardiac cycle. That is one contraction and then relaxation of a myocardial segment. These curves can show a classic pattern where it can come down, but you may get a little bump before you get to actually where the aortic valve closes, right? Which is the true end to systole, when the aortic valve shuts. That is the definition of the end of systole. Unfortunately, the ECG doesn't always match up with that. So you can get an area where you can get pre-peak systolic strain. But you can also have areas where you get post-systolic strain. And so what the aficionados, if you like, of strain would say, anything that happens before the aortic valve close, that is the true systolic strain, right? Because that's where you're getting, if you want to call it, constructive contraction. And that's where the myocardium is contracting to eject blood from the LV, and that is true systolic function. Anything that happens after it, as in post-systolic shortening, if you like, anything that happens after there would be inefficient contraction. And this would be something that might be considered a heart that is not contracting in a positive manner, maybe, okay? So we can even get on one simple curve, we can get different ways of assessing what strain is. And what I think is really, really important to note when you're starting to look at any kind of paper that discusses it is how the hell they did it. Because often when you're starting to do, you see these big multi-center trials that look into strain and they start adding papers together that have done strain, and the critical care literature is the worst for doing this, and everyone is doing something different. And I think that's really hard to try and compare data. So if you're going to do any evidence or any studies that look into this, it's really important to find out what they measured and how they measured it. And we'll get onto that a little bit more. So other interesting information that you can get might be exactly how well the heart is contracting in terms of synchrony. Okay, and what we mean by that is you should be seeing all the segments contracting together. That is a heart contracting in synchrony. That is a heart that will be ejecting blood in an efficient manner. If you get different segments contracting at different times, you will get dyskinetic motion. The theory being, and again, I steal this idea, if you look at something like a vortex, right? The heart, as I say, contracts in a twisting fashion. That's so that it can create vortices within the LV. If you have a heart contracting in a synchronized manner, you create a vortex. If you have a heart contracting in a dysynchronous manner, you get a jumbled ejection of blood. If you take a glass or a beaker of water and you swirl it around in a manner and then you put it down on the desk, there's potential energy that's left in that movement, and the heart carries on spinning and the fluid carries on spinning around. If you have a glass and you sort of put your hand over the top or a lid over the top of it and you shake it just up and down and then you put it on the desk, it sort of stops fairly quickly and the movement ceases very quickly. And that's because you've got dyskinetic jumbled motion. So if you've got synchronized contraction, the idea is that you get better motion of blood from the heart, all right? In things like septic cardiomyopathy, we've got evidence to show that maybe we start to get desynchronous motion as well as poor systolic function. So it's almost you're getting like a double whammy of bad systolic ejection of blood from the heart. And so what we can see here is A is a normal heart where all the curves come together at their peak pretty closely together. Here in a septic cardiomyopathy, you've got one peak here, you've got another peak here, then there's another peak over here. It's late, it's after the aortic valve is closed, so we've got a lot of post-systolic shortening, as in inefficient contraction, all of which pointing to a badly functioning heart. So again, Speckle tracking can give you really useful information about dysynchrony. And they've used that in the cardiology literature to try and do things like time pacemakers and things like that. We can get other things other than strain. We can look at the rate or the time it takes for strain to occur, and we call that strain rate. Right? It's a bit like tissue Doppler imaging, to be honest. But here we can have a look at, so if this part is systole, again, from the beginning of the QRS to the end of the T wave. So this part here, if you can imagine, that's still shortening all of that, but it's the speed of shortening. So as that thing shortens, it goes quickly, 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 then it gets slower and slower and slower and slower till it gets to its final point. And then as it relaxes, it goes fast and then fast again during atrial contraction. So it goes quickly and then stops, and then back slowly and then faster and slower again. So you get the strain rate systolic, or the SRS, strain rate early diastole, and strain rate late, or SRA, it's also can sometimes be known as atrial kick. So we can get a lot of starting to get measures maybe of other measures of systolic function, other measures of diastolic dysfunction in there as well. Looks a bit like tissue Doppler, right? Where you've got your S prime and the E wave and the A wave, but it's just upside down. And this has been used in a handful of studies. I think I've only seen one or two where the diastolic one, SRE, has been used by one of my heroes, Landesberg. She's an amazing intensivist. But anyway, they've looked at this E over SRE ratio, maybe say it's important. Again, very, very research-based, but there are a handful of studies that have gone out to look at this. So, you know, you can get lots and lots of information. There's one I haven't mentioned, which I think is really interesting, which is this idea, again, we can look at speckle tracking in the short axis, and you can get an idea of how much twist and torsion is happening in a heart. And speckle tracking can actually give you ideas about how the heart twists and moves together as well. So lots and lots of information can come out of speckle tracking. So that's all the good stuff. What about the bad stuff? Well, one of the bad stuff is that it's pretty complicated, and it's a bit like Apple and Microsoft talking to each other or not talking to each other. There are vendors that everyone does it in a slightly different manner, and they assess these measures of strain in a little bit of a different way. So this is arguably one of the best papers that's done that's looked into the reproducibility of this. And as you can see, these are where they took a collection of, oh, I've forgotten the exact number, but it was a good number. It was like 60 to 100 cases, and they analyzed those images across every known vendor at the time in 2015 who was doing strain. And if the mean was somewhere around about 19, they're all a little bit out. It's not horrific, but it's also not perfect. And what this called is for the community called for vendors to try and make the ways that they were analyzing strain for longitudinal systolic function as normal as possible. And the idea has come out that it's okay, the intervendor reproducibility, but if you're going to be comparing someone, you know, on day 1 versus day 10, just make sure you're using the same machine to do it. And that's what this is said here. So they recognized there was a need for standardization, right? And at the end of it, they called that for us to try and ask the vendors to do their best to try and do things in a similar manner. And if you're doing one thing, just do it on the same study as I said. All right, so how the hell do you do it? Well, the bottom line is it can be a little tricky, and it's not something that you need to give to your medical student to go away and analyze. I think if you want to do it, you've got to be pretty good at echo first of all. So there's a process that you should follow. Kaz Nagishi here is one of the leaders in doing this. He put out a beautiful paper describing how to do it. So the first thing is you need to have an appropriate image. So you need to image in a specific manner so that you can do the speckle tracking. You need pretty good images because you've got to be able to see the myocardium throughout the cardiac cycle. So that's problem number 1 that we have in the critically ill, that they can be bloody hard to image. Second 2 is that you need to make sure that you can, get decent tracking, because if your tracking algorithm is not following a myocardial segment properly, well, you're not going to be checking the right thing, okay? But if you've got both of those, if you think you've got okay images, once you've pasted or painted the myocardium and you watch those speckles move towards each other, you think it looks okay, then you can move on to having a look at the curves, right? When we look at the curves, you've got to think, does it make sense? When I look at a heart, does it look normal, mild, or moderately or severely abnormal? If you think it looks okay and you've got the function looks all right, but you've got curves that say that you've got severely abnormal strain or you've got dyskinetic segments, something's probably gone wrong with your speckle tracking. That's what I mean about you've got to be okay at looking at echoes to begin with, because you've got to make sure that what you're looking at matches up with your curves, all right? And once you think that you've got curves that match up with what you're thinking, you've then got to repeat it. And I repeat it 3 times to make sure the numbers I'm getting are approximately the same. So it takes a bit of time, is the bottom line. And to do something like global longitudinal strain with half decent images, so you've got to do it in 3 different sections. I think it takes about 25 minutes to try and do, maybe 20 minutes. You get it quicker, but it's about then to do half decent imaging. So I'll show you some examples of what we might be looking at. So, okay, top left image, that is an example of an image that is good, good tracking. It's a good image. I reckon I can see the myocardium and the endocardium throughout the entire image. That is okay, all right? This second one down, the apex, I can't really see that brilliantly. It's not awful, but I might have difficulty. This 2-chamber down on the bottom right, I'm finding it a bit tricky to see all of the myocardium there, particularly in the anterior section. It's super common. And so I might think that the anterior wall might be tricky. Does this mean I'll stop having a go? No. You can choose on this software if you want to ignore segments. And the general rule that we use is that you can ignore a couple of segments, but you can't ignore 2 segments that are the same or next door to each other on 2 separate images. So for example, if the apex and the anterior wall was bad here, and then the apex and the anterior wall were bad here, you can't do global longitudinal strain. The latest thing there is therefore to say, well, if you don't see any obvious regional wall motion abnormalities, I can probably say that I don't think there's any major regional wall motion abnormalities in this 3 in this 2-chamber, if you can't see any major abnormalities, the evidence would also suggest that maybe you're okay just using your apical 4-chamber. And certainly that's what's been used in the critical care literature, is just to use that as long as you can't see any major regional wall mesh abnormalities. You know, maybe it's a cheap way of doing strain. I'm all for that. Okay. What about some, you know, where you're placing your strain curve? So once you've asked the machine to do some speckle tracking, and this is an example of the Single Dynamics or the Tomtec system that can do speckle tracking, you're meant to place your region of interest, if you like, just on the endocardial border. So on the inside, not on the outside. You're meant to ignore trabeculations and ignore papillary muscles. So just like you're doing where you put the marker for your ejection fraction, if you like. And then when you tell the system to press go and see if it can track well, this bottom image is an example of good speckle tracking, right? Just watch it for a little bit. Does it move with the myocardium? And I look at it all the way around. I think that's moving pretty well. Look at the top one. Straight away, we can see that maybe this bottom part down here, I mean, look at that one. That's flicking right out into the middle of the myocardium. At some stage, that basal segment looks like it's tracking the anterior leaflet of the myocardium, of the mitral valve. You know, the apex, it's nowhere bloody near the endocardium of the apex, up at the pericardium. So this is no good, all right? So this is somewhere where you've got to ignore that strain and do it again. Let's have a look at another example of badly placed myocardial segments. So this is on the Phillips system. Here we got exactly the same image, being one is imaged well and one is imaged badly. Look, we've got this one strain curve here where we've got a severely abnormal myocardial strain value. So that one represents the yellow segment. The yellow segment here is the basal infraseptal segment. All right, and you can see it over here, basal infraseptal. It's got dyskinetic motions. That's severely abnormal. If we could train our eyes to have a look underneath, we can see that that's actually moving and it looks like it's thickening. So something's definitely out. And you can see that this basal segment, it looks like it's tracking half of the atria, right? So this would be an example of where we've got a badly placed region of interest. And if you put it in the right spot, as you can see at the bottom, it actually shows you you've got a normal strain curve. So that's why you've got to have a good understanding of speckle, or good understanding of normal heart function before you start jumping in to look at strain curves, right? Okay, so one of the problems that we've got in the critical care literature is I think we've got a lot of people who maybe didn't know how to do speckle tracking who started doing studies in it. And I'll put my hand up and say I probably am involved in that. You know, I published some papers, I think I show them in a sec, using speckle tracking when I was learning it. I'm not entirely sure, looking back on it, that I was good enough at strain to maybe do some of that when I did. I thought I was. I'd maybe done 50 images before I started doing that. That's probably okay. But we know that the more you do it, the better you get. And so I guess when I'm looking at some of these studies that are coming through from the critical, it's often one of the first things I look at. Okay, who was doing the speckle tracking? Were they good at echo? Do they know how to do echo before they started doing it? How did they analyze their curves? What data did they get? How did they do it? Is it pre-systolic strain? Is it post-systolic strain? Is it just the maximum negative value? You know, how did you do it? How did you choose regions of interest? How did you decide that your curves were okay? Did you repeat imaging? Did you get others to check what your images were? You know, what's the iterative variability? You know, these are important things to look at when you're assessing literature. You know, we've got studies here done by some friends of mine, Filippo Sanfilippo, you know, Nick Fletcher, Antoine Villabaron, you know, Mauricio Ciccone. These are some of the greatest in the game. And they've done these meta-analyses that say that worse strain from, so they've added together, you know, these 8 studies, mine's included in here. Now they've added together all of the data and they say that we've got evidence to suggest that worse strain values, so worse global longitudinal strains associated with high mortality in patients with septic shock. You know, I look through these studies and we can see that there's a lot of different ways and different vendors and different criteria for measuring these. And you've got people who are looking at just one apical 4-chamber view chamber, which is not, and often some of these views are not optimized for speckle tracking. Again, you're meant to have frame rates that are greater than 50. And a lot of these studies did not talk about how they selected their strain curve studies. So I'm not saying the study's wrong, I'm just saying you've got to take the results with a pinch of salt, and that may change the results, I don't know. But going forward, I think we've got to be a little bit more robust about how we do our speckle tracking in the critical care literature. So this is some of the literature that I found that supported their findings of, it didn't support their findings that worse strain was associated with worse mortality, but as an example of how I did it, I guess. We had 60 patients with severe sepsis and septic shock. They had an echo within 24 hours of arrival. And with conventional measures, we saw that there were a third of people had reduced ejection fraction, and a third of those had severe systolic dysfunction. If we did it with speckle tracking, we saw that those numbers almost doubled, if not tripled, with severe systolic dysfunction, and it quadrupled with the RV, suggesting that speckle tracking picked up cardiac dysfunction that ejection fraction could not, and fractional area change and TAPC could not. All right, I think that's in keeping with the cardiology literature. We saw that LV, the systolic dysfunction, was not associated with worsening mortality with my cohort, but the RV systolic function one was, and that was mainly due to the severe RV systolic dysfunction group that all died. All right, and you can see they died within 20 weeks. Right. So this sort of disparity in the way that we're doing speckle tracking led a group of us to get together. We did something called the Prices group. It's looked at all kinds of critical care literature from the last 25 years. And we looked at the way that they were done, particularly methodology of how people are doing critical care echo literature, or critical care echo studies. And this was, I was involved in the group that looked at some of the advanced technologies, including speckle tracking. And you can see here that out of all the groups, we can talk, these lines here are the orange, shows about the number of studies that, all the studies that did speckle tracking in the last 25 years, what they reported in their methodology. And if it's 100%, everyone reported it. If it's 50%, only 5, 50, if it's only 0.5, 50% of them reported it. And so you can see there's a bit of a disparity. If we included everything that we thought should have been included in critical care studies, if they could, if you're looking at doing any kind of stuff, you've got to talk about how images were optimized. Did you reduce your depth and narrow your sector width so that you can improve your frame rate? Only, 14% of studies did that. Did you talk about how you excluded images? No, only 0.25% of studies did that. Did you talk about how you excluded segments? Did you talk about your frame rate? Blah, 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 blah. And so it's not perfect again. And so this was a call to arms that we need to, if you're going to do studies in this area, just try and report this stuff so that at least we know that we've got robust data. I didn't do all of this in my study, if it'd be good to know. So it's don't do as I do as I say, or something. We're trying to get better. It's still a work in progress. I'm not suggesting that my studies are perfect, but it's the kind of thing that I'm going to try and do with future studies. Okay? The area that's probably got the most use for this technology is the right ventricle. And the right ventricle is useful for this because it's got the majority of its fibers are in the longitudinal direction. It's got little bellows function. And that means that it's absolutely right for the picking, for looking at longitudinal strain. And you only need one image. You don't need 3 like for the LV. You do need to have a little bit of a specific way of analyzing the images. And that means that you need to have these RV focused views where you're trying to see the RV myocardium throughout the cardiac cycle. All right. Probably not the most perfect image, but you get the idea. With this echo probe that's placed on this sort of phantom in this apical 4-chamber view, you get a standard apical 4-chamber view. If you slide that probe a little bit more medially and angling it a little bit more sort of in towards the spine, you can get these RV-centric views, and these are perfect for doing speckle tracking. You need to reduce your width and reduce your depth. and that improves your frame rate, okay? And that helps you get the best tracking possible. You paint the myocardium and you get an area, something that looks like this, and you just want to have a look at the 3 segments. You don't want to look at the septum, all right? That's what the literature tells us, and we can argue about that some other time. And here's a normal strain curve where we see the curves come together nicely, kind of matches up with what eyeball looks like normal systolic function. And the magic number for the RV, if you take the average of all of these 3 sections, is -25 or -21, depending on what vendor you're after. And that's normal.
So what's our vendor?
So this is GE, and so we use -21 as the normal.
And that's just the average.
Just the average, absolutely.
Okay.
And here you can see they're approximately down there at -25. So this would be normal strain of the RV. And it's not hard. It takes maybe 5 minutes of a push. If you got decent images, it takes about 30 seconds. I still repeat it 3 times to make sure I'm getting right numbers.
You repeat with the same image or different images?
Good question. I do it with the same image.
And
And
you get the answer you want.
see, this is the right. You can get the answer you want. It's a bit like ejection fraction, right? I can make an ejection fraction 35, or I can make it 50. But you try and do it in a systematic manner, and you can do exactly the same with speckle tracking. If you move the region of interest closer towards the outside, or closer towards the outside, you can make the number worse. If you move it closer towards the endocardium, you make it better. And that's why you've got to, as you're starting it, I love to see studies where they've got it completely blinded, where they don't tell anyone what you're trying to achieve, and they just say, there's 50 images, analyze and tell me the data. You know, that's when you know that you're doing the same thing every time.
But when you're actually creating the width of the image, isn't it supposed to be overlying the whole image?
Do you mean the width of the whole image, or just the
No.
width of the region of interest?
When the region of interest, so
I'm
the
so
middle
sorry I haven't
bit, the
said
middle
that.
bit is the
Yeah.
middle bit of the muscle. isn't
So
it?
you're meant to try and cover 95% of the myocardium.
Yeah.
So you're meant to
it
cover
has
from
to
the
match
inside to
the
out.
wall.
On the Siemens machine, it just looks at the endocardium, which is why the values are a little bit higher. But in GE, they look at the central bit. It's like an average of all of it.
Yes.
So they're all doing it slightly different ways. Sorry if I hadn't said that before. Excuse me. Thank you. And so for the RV, you know, I think it's pretty good, right? It's quantitative, it's sensitive, it's reproducible. You know, you can do it on the reporting station afterwards. Single loop's okay. It's angle independent. It's less subject to this translational error, or the problem of different parts of the myocardium being analyzed depending on what you're doing, like TAPSE, right? If you've got TAPSE, just that M mode, you can get a different part of the myocardium coming into the view. And so that's a bit tricky. And we know that it's really good in pulmonary hypertension. So we got big studies like this one done, like from 600 people almost, done from the guys at the Mayo Clinic, like Noel and Garvin, Kane and Jo, you know, some of the best in the game. And these guys are amazing images. Like this Paul Bastiansen is the main echo guy at the Mayo. You know, he's an amazing imager. And then, you know, they've analyzed these prospectively, and then just gone back into collected the data, and they find out that RV free wall strain is really, really good at predicting mortality and, you know, time coming into, you know, readmissions to hospital. And they're looking at these guys over, you know, a year and a half. It's pretty solid data, I think, to show that it's useful in the pulmonary hypertension. And as with all good critical care echo research that I've done, I've stolen ideas, all of them from cardiology. I started using it in the critically ill, and I think it's showing it's pretty useful. So here's a 74-year-old guy. He's admitted with hypoglycemia, not feeling well, lots of small ulcers on his feet. He's got lower limb swelling, acute kidney injury, acidotic, coagulopathic. Does he have RV dysfunction? This could all fit with RV dysfunction. We have a look at his echoes. We've got someone who's got a generous size right ventricle. He's got normal LV systolic dysfunction. He's got a septum that maybe looks like it might be squashed a little bit. He's got pulmonary hemodynamics that suggest he's got significant pulmonary hypertension here, got the flying W sign and a reduced pulmonary acceleration time. These findings are backed up in the apical 4-chamber view. But what do you think of the RV systolic, the systolic function?
So I'm trying to work out what the TAPSI would be.
Yeah, nice.
The thing on the right.
If you have
that
to
would
eyeball
probably,
it.
yeah, well, I'm losing the scale on the right. But if you do, so it's probably, the TAPSI is probably all right.
Yeah.
But what you can't see is, you can't see the free wall actually moving in very much.
Nice.
So I think you would have to go to including fractional area change.
Great
and
job.
I'll probably do
Great
strain
job.
on that.
Great job. Fantastic. It's exactly right. Because eyeballing it, you're going, it's exactly what I was doing with this one. It's like, it's, you know, that's, I don't know, that's maybe someone would say, I think particularly people who maybe haven't done as much echo as you would say, yeah, that looks normal. But you're absolutely right, is that if we have a look at the TAPSI is completely normal. It's greater than 16. If we look at the S prime, it's greater than 6.5. It's you know, greater than 8, whatever value you want to use. But it's 9 or 10. That's definitely normal. You've got fractional area change. That's 25%. So that's on the cusp, right? That's not sounding
it should be up to
quite
35%.
normal. Exactly
so
right.
that's
So
moderate,
and so
mild
that's
to moderate.
mild to moderate. So that sorts out exactly what you're saying, Louise. It's really good. This is a great example of when to use fractional area change. And this is completely backed up with the strain. That if we're looking at that, it's suggesting that we've got severe RV systolic dysfunction. These are the kind of things that, this is where maybe Speckle tracking wasn't perfect. You know, this is measuring it right here instead of out here. Again, we can argue some of the technicalities of that. But strain is definitely abnormal and definitely supports that fractional area change and what our original thoughts were with our eye, that maybe the RV function is not normal. So this is someone who I would say would have mild RV systolic dysfunction, yeah, if not moderate. And I guess that would depend on the clinical picture. And with someone who's got that clinical picture of that, I'm definitely then leaning towards saying moderate RV systolic dysfunction. We've got an RV that is at risk.
So where the green line goes through it, if it measures it from there, what is the timing for the right ventricle?
That timing is based on aortic valve closure.
Well, isn't that a bit dodgy?
Absolutely, it's a bit dodgy. And that's why I was saying we can argue about the technicalities, is that aortic valve closure is obviously not when the RV systolic dysfunction is actually ends. It actually happens at the end of pulmonary valve closure. And so these are the kind of things that we could potentially look at and actually move it towards maybe the end of the T wave.
Wouldn't you want to go through the deepest point of the curve anyway, to some extent?
I think you can choose how you want to do it. You just got to do it the same way every time.
Well, on that one, it looks like it's only not even, only just over 2/3 of the way down to the peak.
These are where
So
that I normally do the RV free will strain. Absolutely right.
Yeah, so that you manually, is it okay
Yeah.
to manually do it? Yeah,
Absolutely.
if it's not correct.
The reason why I was probably doing it is I'd already done the LV and I was probably being lazy, and so I didn't change the aortic valve closure. It helped my point to say the RV dysfunction is down. Again, lazy echo clinicians. That's what I say. So yeah, the RV dysfunction and dilation is at risk, and therefore treat it as you would any other RV at risk, and avoid fluid overload. Reduce your PEEP as much as you can, not too low, not too high, find the sweet spot. Avoid anything that's going to increase up your pulmonary vascular resistance, such as hypoxia, hypercarbia, and acidosis. And if you're running into trouble with acute kidney injury, look at earlier institution of dialysis and fluid relief. Okay, another example. I'm sorry, I'm going to just push through these pretty quickly. Again, we've got someone who's got a bit of a dilated RV. All the numbers look okay, but you've got an RV that again looks a little bit abnormal with RV free will strain of -16. So you can see this was the patient after we'd instituted all of those parameters. The RV looks much better, and we can see the TAPSI's got better. The S prime's gone from whatever it was, I think it was 8 and 10 up to 16. I think the septal bounce has markedly improved, and the RV fractional area change has improved, as has the regional free will strain. Okay, what about ventilation? So we did a study just trying to have a look at that subjective estimate versus the strain and how it matched up with conventional and the Speckle tracking. And what we could see is that we looked at 80 patients who were just a bog standard bunch of patients from mechanical ventilation who had a PF ratio less than 300, so a fairly heterogeneous group. And we saw that they had abnormal TAPSE in 2/3 of them. And here's the guys with the strain. So there was only 1/3 of them that had normal RV function based on the strain, and 1/3 that were normal with TAPSE. So quite a lot of RV dysfunction we found in this relatively nondescript group with PF abnormalities. So that's just showing, I guess, how much strain can be useful in that group. We've done other studies looking into peaks on PEEP, and we can see we did these sort of stepwise escalation maneuvers trying to compare fractional area change with Speckle tracking. And we found that there was a lot of value that we could get from trying to have a look at the right ventricle with Speckle tracking in this group. So here we can see at peeps of 0, where they had normal strain and strain rate, we saw markedly abnormal strain and dysynchrony that would occur when we gave them silly high levels of PEEP, all right? And if we compare to fractional area change, for example, here's the sort of the impairment in fractional area change with escalating levels of PEEP in these poor pigs that we abused. And with the Speckle tracking, we found that it was much, much worse. So again, supporting the idea that Speckle tracking is more sensitive than some of the standard measures for diagnosing RV dysfunction. Doing this in patients is something we've tried. So here's a 44-year-old lady, obese with atelectasis, who's having a relatively simple procedure and they couldn't take her off the ventilator. And she came around to us on good levels of PEEP. She had high FiO2 requirements, giving a PO2 of just 72, you can see up here. So severe PF ratio abnormalities with good going atelectasis in that right base. She had no PE that was going on. We try these sort of standard de-escalation PEEP maneuvers to try and look for optimal PEEP in certain patients. And I use these sometimes for patients with severe atelectasis. I thought this patient was a good candidate for it. I follow recommendations from the ART trial and base them off a little bit what was done in the FARLAP study. I use volume control to try at this stage, I was using volume control in these normals. I don't think that is the way to do it. I'll be honest for now. So I have changed the way. I think you've got to fix your PEEP, your pressure high. So I actually try and use my driving pressure now and look at volumes instead, because doing it this way, you can cause high pressures. So just please, that is something I've learned through error. It doesn't take 34 minutes anymore. I think you can do this much, much faster. You just have to wait for 6 cycles of the breath. So I have changed it a little bit since this. But you get the idea that maybe you could start getting a whole bunch of data, and you can start to get an idea with hemodynamic data, ventilation data, as well as echo data potentially to add into that, where you can get an idea of where the optimal peaks would be based on looking at the hemodynamics, looking at your plateau pressures, and looking at your resistance and compliance, and trying to look at where you get the best for your change in pressure, getting your biggest bang for your buck in terms of the volume, or the other way around if you have a fixed pressure gradient, driving pressure, having a look what you get the biggest volume for would be the way that I do it now. If you add an echo to this, you can also have a look at what's the best way you can look at your RV. I was trying to do this with strain in this case. So I'm going to paint this RV free wall. And you can see here when I started at baseline of 10, I had a strain value which was normal. As we started to go up to the highest peak value I got to, which was 40, which is, I think, probably potentially a little bit punchy. Probably I got up to 30 these days. You can see I started to get some mild RV dysfunction and a bit of dysynchrony that potentially might have come into this maybe. As I then came back down to the best peak based on the compliance data, I saw that I've got actually better strain than when I started with. I haven't done many of these, I'll be honest, but it's something to think about that, you know, this patient clearly had better improved compliance and better looking chest x-ray before versus after. maybe the RV was functioning better when we had better oxygenation that was going on. I went to PO2s that showed some improvement up to PO2s of 93 on only 35% oxygen, so much, much, much better PF ratios than when we started with PF ratios of 100. I can't do the maths quickly in my head for what that is, but I think it's greater than 300. I should have figured that out before I did it. But, it's markedly improved, and so it makes sense that the RV might be functioning a little bit better. So, I don't know. In conclusion, I'm going to say that speckle tracking is absolutely standard of practice in cardiology, looking at the LV in things like chemotherapy-induced cardiotoxicity, and in the pulmonary hypertension literature, a lot of centres, the larger centres, are doing it to look at pulmonary hypertension. It is far from mainstay in the ICU, in my opinion. I think if we're going to do anything, let's look at it in the RV, because it's easy to do. You can do it in about maybe 85% of patients. It's got much more clinical relevance to try and pick up these RVs that are at risk. The LV, you can do it in about 75% of patients, but it takes a bit more time. If we're going to start looking into this, though, it's got to be robust, and we've got to have people doing the same things, and we need to have people who are doing it who are pretty well trained in echo, because otherwise you're just going to get a whole bunch of dodgy data. All right, but it's something I'm certainly going to carry on researching. I think it's really interesting. It's got clinical utility in my experience, and I don't think you need to do it in everyone, but it's good for looking at those RVs that are at risk. And that's it. Are there any questions? Thank you for listening.
Can I just quickly ask or say something, Sam?
Yeah.
When you read about it, it says in the, say, concentric, constrictive cardiomyopathy, the circumferential strain is lower than the longitudinal strain. Do people do circumferential strain also?
Yeah, it's very research-based. I think what we found out is that circumferential strain hasn't added much to clinical utility. I think that's the problem. So I think if it's clinically useful, we find that the data goes up, right? Circumferential strain is looked at purely in research. There's nothing clinical that uses it at this stage. So I think it makes sense for constrictive cardiomyopathies, right? Because you often have horrible septal bounce going on. And so the reduction that you're going to see in the circumferential strain would be related to that you've got impaired, that myocardium from things like radiation or post-cardiac surgery. The myocardium is fixed, and that means it stops that heart moving, but it still tries to compensate for it in that longitudinal sections. So it makes sense. I buy it. I think it's sensible. And we know that the inside, the septum tries to work more. My argument is, though, if you've ever tried to do speckle tracking and you're doing longitudinal strain and then you're also doing circumferential strain, we're talking about an hour of data. I remember I had a friend who was doing their PhD. She was an amazingly smart cardiologist doing a whole PhD into constrictive cardiomyopathy at the Mayo Clinic, because they got so much constrictive cardiomyopathy there. It's like this amazing center for it. And she was spending an hour a patient doing this speckle tracking, and we were all doing these speckle tracking studies, the research candidates, and we were all just like, oh my God, it's taking so long. And the person who was spending the most time doing it was the person who was analyzing constrictive cardiomyopathy. And in the end of the day, I think we have this data that helps support what we see with our eye, right? We can see it when we see the septum moving more. And so I think it's great for getting literature published and trying to get more information about speckle tracking. I've got to say, I find it hard to imagine it's going to get into the mainstay of cardiology literature, because we can find that information very easily with tissue Doppler imaging.
It just got me interested mainly because it's not even there in my GE Echo machine, that software for the circumferential. And when I was studying now, I just got the longitudinal one. And when I was studying, I said, it got me wondered why and how.
Yeah, I think it should be, if you got speckle tracking with I'd have a chat with the GE, the GE, rep, because it should be there. If you've got longitudinal, you should have circumferential, and it's normally there under the, if there's an apex and a basal cross section, it's normally got that in there. the thing that I reckon it might be super fun to have a look at and what it might be useful for, and this is a stretch and just, dreaming out there. If you look at some literature, and it's not perfect, we know that the heart has, so if this is the base of the heart and this is the apex, they go in opposite directions and they come towards each other, all right? And that's called torsion and twist. And you get twisting during systole and you get untwisting in diastole. And the distance that they come together and how many angles is the torsion, all right? Keep that in mind. If I then also said to you, if I gave you a wet rag and asked you to get the water out of it, we twist it, right? And that's because it's an efficient way of getting water out. There are people out there who say that it's also the efficient way of making vortices inside the heart. If we then take in this idea that dyskinetic motion and things, are also bad for making vortices of blood, and that's how we get efficient flow of blood down through our big blood vessels, I reckon that this twist and torsion of the heart is going to have a massive deal to play with how efficient we are at getting blood out of the heart. The only way that you can analyze that non-invasively is with circumferential strain. But you're not looking at the strain, you're looking at the amount it moves. So it's the number of degrees of motion at the apex and the base, and then you look at the distance that they move on like a standard 4 and a 2 chamber view, or you're doing it with 3D strain, which I think you probably got to do it with toe in the critically ill. But I bet there are studies out there that talk about torsion contracting, that contraction from the torsion accounts for up to 30% of systolic function that we don't even look at. We're not completely oblivious to it. We're not even looking at it at the moment. But the only way that we can do it is a speckle tracking. And I'm going to bet that in the future, they're going to look back on us and they're going to find some amazing way of doing this non-invasively with toe and stuff like that. And they're going to look back and they say, what were those people thinking of in 2021? They were still interested in ejection fraction. What were they thinking? It's such a rubbish measure of systolic function. Why weren't they looking at twist and torsion?
It makes so much sense. Yeah, it makes so much sense because the way myocardium is arranged, outside muscle fibers are circumferential and inside are longitudinal. Yeah, exactly. And we are only measuring the inside ones and we are totally ignoring the outside
completely
ones.
But it does make sense because the inside ones, and again, I probably should have put this in the talk, but the inside ones, the endocardial ones, they're the ones that are most sensitive to ischemia because they're the furthest away from the epicardial coronary arteries. So that's why longitudinal strain makes sense. And I'm sorry, I should have definitely mentioned that in my first slide, shouldn't I? Those are the longitudinal strain makes sense in the LV because the endocardial fibers are longitudinally directed and the most sensitive to ischemia. So I think strains, speckle tracking is interesting. It's pretty researchy based, but I really like it. It's a bit geeky, but I like it.
Sure.
And it's great to see you. Thank you very much, guys. See you later.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.